haven't started with a welcome. So thank you all for signing up to the session, and welcome to the session on client health. What we're hoping to do with this session is tell you about 3 different areas of health related work that we've been doing in the organisation over recent months and the last year. So one of them is the community of practice work that's been looking at client health in hostels. The Sport and Health project that's been running for 18 months, nearly 2 years, in 2 years now actually. And then the work within Flick that's been looking at their client health, and in particular with a focus on wound treatment. But before we start, we'd like to take a little bit of a straw poll of your views. So we're going to move. So if you've got have you got your mobile phones handy? So we're going to just show an image in a second.
There you go.
So if you're either able to scan the box on the screen or go to the website that's top and bottom and just kind of dial into that website. I think the website will be on the next slide as well.
It's at the bottom as well.
Yeah. So, okay. Shall we move to the question? People okay to, so the website, if you're still logging on, is on the top of this slide as well. So question, you can, I won't read it, but are the clients that you support, and I'm conscious some of you won't be, but receiving the healthcare that they need? So at the moment, the trouble is we don't know whether one person's voted or everybody's voted, and we've got 100% no's. So we just give it a couple more minutes to see if the number changes. Oh, hang on. I might need some technical help. There's a 7.
Oh, yeah, the hand's fine. Just ignore the hand. It's just,
okay.
Yeah, I was trying to work out what it was.
So hopefully this is working.
I'm sorry, I'm kind of behind a bit.
If you log in, see at the top of this slide, there's a website address. So it's ahaslides.com 3E5E7. If we move to the next question, so at the moment we've got 100% of everybody who has been able to put in an opinion think no, and then so the next one, oh, we're moving through them rapidly. So people overall feel confident in helping people access the medical support they require. 50-50. Slightly more no.
A live poll.
It's like
do we win £1 million at the end of this? That would be good.
Where do you vote at?
Sorry, I was talking.
Where do you vote at? I can't see which button to click on to vote.
If you open the chat up, there's a link that Lou's put in the chat. If you just click it, it will take you to a website.
Oh, now it looks like I've been thrown out.
I think if you click on your mobile, it might be easier.
Can we go back? Can we go back over the slides and see the results in case?
Yeah.
So start at the beginning one. So are people receiving? Sorry, go back to. So are the clients you support receiving the healthcare they need? So basically 10% yes, 90% no. The next slide. In terms of how confident you feel in helping the clients access. So 54, so slightly more people feel confident than don't around guiding to access. And then the next question. So this is if once you guided them, do you feel their needs will be met? And unfortunately, our faces appear last one. So is that a sometimes?
I think some of their needs.
Some of their needs. And then the last question here is, has COVID made a positive or negative impact on the healthcare your clients receive? This is an interesting. So positive 37, negative 62.5. And I think the answer on that's going to vary greatly based on the service that you might be in. I think floating support is going to be very different to accommodation services. And did we have another question? Or?
No, that's the last one.
That's it. So thank you for doing that with us. So we'll start with the presentations now. We'll come back to some more playing on the phones in a little while. Why the first point I suppose to address is why SHP would focus on health. We are largely commissioned as a housing related support service. We're certainly not paid to do anything for health other than signpost people into the services that they need. We're definitely not qualified to be delivering healthcare to people. But there are a number of real drivers for this. So one of them is the reducing average age of death of rough sleepers on London streets. And at the moment, the average age at death is 44. And that has to be a point of concern. And linked to that is the fact that many of these deaths potentially could have been prevented. The kind of next reason for us focusing on this more than we might ordinarily was the sport and health program. And I'm going to leave the details of this for Eloise to tell you far more expertly than I could about them. But we were starting to do health checks through that program. And the results of those health checks were really alarming in terms of the general well-being, and far worse than was being recorded in general support planning. And I think the other thing that we then did was move to looking at a piece of research across our accommodation pathway services in 3 boroughs. And that also was telling us that the level of unmet health need was significant. And the kind of accounts that were coming back from caseworkers, and particularly through reflective practice, when we were asking people to kind of give us lessons learned from the discussions that they were having, one of the biggest areas of concern that was getting fed back were not knowing how to manage the level of pain that people were in, or get treatment to people quickly enough, but also knowing that clients themselves were self-managing that pain through their substance use. And that although workers were trying to make referrals into health services, for whatever reason, clients weren't able to engage with them. And that was leaving a situation, both with health and care, that the staff felt unable to continue to manage safely. And then the last point is, because of sport and health and because of Flick, we were starting to build a really large evidence base to start to argue for change. And we were told, unbeknownst to us, that the data that was being collected as part of the sport and health program is actually the largest database on rough sleeper health anywhere in Europe. So we need to do something with it. If we move on to the next slide. So I mentioned the community of practice and the fact that we were finding that the level of health needs were pretty serious amongst our formerly rough sleeping clients. So we looked at Camden, Islington and Westminster, and we went back over an 8-month period from September 2019. And we did a kind of a detailed delve into risk assessment and support plans, as well as that kind of health issues recorded. And we were looking at 384 clients over that period. And nearly 50% of them had serious physical health conditions. And there's a star there because I meant to put in what those conditions were, and you haven't got that slide. So I apologise, but these are life-threatening conditions. They're not a cold or a bit of flu. These are things like sepsis and untreated open wounds and sores, and type 1 diabetes where the medication isn't being maintained. So 40% of all of those that we'd identified with serious health conditions are not engaged with their treatment regime. And about a further 12%, so that's 44 individuals, on top of having that health need, had additional care needs. So they needed domiciliary care to help them live their daily lives, and that wasn't in place. So once we'd realized that we had that number of people with really acute needs not being met, we looked at what happened to them over an 18-month period. And that of those 44 people, you can see it's not quite a third, but less than half actually got a care package in place. Half of them hadn't had their care needs met, and a quarter had died from their underlying health needs. And I mean, some of them were quite elderly at that point, but they were people who had died in a distressing way without suitable healthcare in place at the point of their death. And finally, I think the kind of combination of looking at all of this data and the work has called us to start looking at what we think the solutions should be. And we're going to throw this open in more detail later. But some of the main findings here were the fact that we think that integrated commissioning that needs to link physical health, mental health, and homelessness together along with substance treatment. And to be able to provide treatment to people, it needs to be done through multidisciplinary teams. And those teams need to be outreach based. They're not just sending our clients to a service. They need to come to the services to see the clients. We also had been picking up on the poor response that our staff get when they make a safeguarding referral. And one of the things that we thought could make a big difference is having social workers who are dedicated to homeless accommodation pathways, who actually can make the case for the clients with some knowledge about the needs that are being presented. I think in terms of the care, we were looking at alternatives to care homes. Our clients are often much younger than the people that would typically move into care homes. And we're looking at offers that or care that could appropriately be delivered in situ rather than necessitating a move. We also have kind of discovered that when health checks become present in services, people start actively thinking about their substance use when previously they'd have been defined about as being pre-contemplative. And taking a health first approach starts to move what felt like intractable and long-term substance use. I think one of the most kind of significant findings, or one of many coming out of the FLIC work, was the need for gender-specific health provision, and particularly where women are the victims of both domestic violence and exploitation, their healthcare was being blocked by other people's actions, meaning that they were kept away often longer than men from receiving really quite urgent healthcare. And then finally, I mean, I've actually already mentioned the last point, but we want a fresh approach to safeguarding. Too many of the safeguarding referrals that come from our organisation end up with no care or additional safeguarding measures being put in place by external organisations, and the only action being taken is internally. So I'm going to hand you over to Eloise to tell you a bit more about the health programme.
Thank you. So I'm Eloise. I manage the sports and health programme for anyone that doesn't know. So the sports and health project started 3 years ago. It started as just me and was focused in 4 boroughs. And now we're 3 years later and we're in 12 boroughs. And there's a team of 3 permanent staff and then lots of freelancers and volunteers. When we started as just sport there was no health element to us really. And health got brought into sport because we couldn't do any sport with the residents without having consent from GPs, which we just quickly realized wasn't a thing. Most of them didn't have a GP or weren't engaged with their GP. So we introduced these health check elements into the program so that we could monitor success and also make sure that people were safe before they started with us. And the take up was just incredible to see that bringing a health check on site was so much more popular than bringing some sport and some food on site. And it was really an opening area. It was a way to start to talk to clients and build a relationship and really understand what they were going through. So as Tony said, we've ended up with a massive data selection of stuff to look at and what to do with. So we've engaged over 600 residents that are just over 55 as the older population were our main focus. So if Katie, if you flip to the... So we start to crunch some of the stats. We're about to release some reports on it, but it was quite significant what we started to see. So just a few of them, but heart conditions were a major, blood pressure, heart rate, family heart conditions were a major factor. And then obviously if you add substance use on top of this, you're looking at a very early death. Most of the residents we saw were either under or overweight, malnourished, and also we introduced a measure that worked out life expectancy, and the life expectancy average for our clients that we saw was 44. So it was quite scary what we were picking up, but also what we were picking up was lots of undiagnosed health conditions, which was just horrendous really to see. So where we are now is we have this database and I'm working with Tony to try and get some more health measures implemented into the charity. But we're also looking at another 2 years worth of the program and opening up what we do and our reach to those under 55 so we can really get a better scope of what's going on, really.
Thank you, Eloise. I'm going to hand you over now to Alison, who's going to talk about the work that Flick have been doing.
Just unmuting myself, that's usually a good start. Can you hear me okay? No, you can, good. Yeah, I'm just going to speak really quickly, just a little bit about Flick and what we did. So Flick is funded by the lottery and we're funded to really look at how the system supports people experiencing multiple disadvantage, which is all of our clients really. And part of the work that we do is looking at where there's an issue, where things aren't working very well, and then trying to come up with ideas around it and build the evidence base so that we can convince people to make changes. And when we started out in our giant business plan that Tony wrote, we didn't really mention much at all about health in it. And it was only after about 12 to 18 months, we found ourselves in the position where 3 of our clients died all within 6 months of each other, all of, kind of chronic long-term health conditions, one of an aneurysm, someone else of heart disease, someone else of liver disease, all things that had they been supported at an earlier stage could have been addressed and probably, as Tony and Eloise have said, they wouldn't have experienced that early death. And we realised quite quickly that we had to do something about it. We weren't quite sure where to start, but I think what we realised was that what our clients really needed was health services to come out to them and not to expect the clients always to be able to reach them. And for those health services to be quite specialised. So in a minute, I'm going to show you a film that just gives you a brief overview of the wound care pilot we did and why that was really important. So we funded a nurse to go out and do outreach into some of the Camden hostels. And we also funded another very lovely specialist wound care nurse to work with clients with long-term leg ulcers, some of whom had lived with them. One guy lived with his leg ulcer for 19 years. A few others were living with ulcers for 10 years, which is just unimaginable. And the reason we funded those pilots was to build the evidence base and then basically take the evidence, take that data alongside all the data that SHP has been pulling together to really start to influence. I'll tell you a little bit more about that afterwards. So we're just going to show you a film now, which has got Jamel, who's our specialist wound care nurse. and one of our clients, Ian, who's going to talk to you about the impact of getting the support he really needed around his leg ulcers.
So my name's Dr. Jamal Geraghty. I'm a nurse by profession, and I've been nursing now for nearly 20 years. And for, I suppose, as early back as my nursing training, I've always had a particular interest in inclusion health. Wound care is no different than any other specialism in the medical nursing field, and it needs to be treated that way.
It's actually both legs. It's about 5 ulcers, and I've had them for about 7 or 8 years. Yeah, wound care should be treated like other things, because it's really important. Not being funny, without the wound care I got at CHIP, I wouldn't have any legs now. So basically, yeah, it should be. I've lost count of how many times I've been admitted to hospital with my leg ulcers. The last time I was in for 5 weeks. Yeah, I've been admitted quite a few times.
So one of the revolutionary papers that was published in 2015 by Julian Guest and co-authors was around the economic burden of wound care in the UK and the NHS. And on average, they estimated that £5 billion is the cost of managing wounds in the NHS and associated comorbidities to wounds. And that is comparable to obesity in the UK. I mean, that's absolutely incredible.
Absolutely superb. CHIP is one of the best clinics that you could ever go to. The nurses are brilliant and they're irreplaceable.
And what is it about the nurses that you find is irreplaceable?
They're just so down to earth. They don't judge you in any way whatsoever. You be whatever you are, right? And they don't judge you. They just take you for who you are. I go to CHIP 3 times a week, Monday, Wednesdays, Fridays, and when I get them done, the feeling's unbelievable. As I said before, it's like that fresh bed feeling when you've been on the same sheet for a while and you change your sheets and the mattress and everything and you get on a new fresh bed. It's like that cosy feeling.
So an example of somebody that I saw was a gentleman in his late 80s who had never injected in the lower limb and had quite an active, healthy lifestyle, some mental health problems, and had been living in a hostel for a long, long time and living with these chronic ulcers for maybe 5 years. We had to sit down together and we worked as a team. And slowly, once that relationship built up and that trust, his wounds started to heal straight away. It was really, really incredible and life-changing.
Daily life living with my leg ulcer hasn't been easy. When I get up in the morning, I'm having to drink quite a bit of alcohol just to stand up because of the pain. When I go down to town, I get on the bus, people look at me, the smell is kind of not cool, and they take the piss. As my friend said, if it was a broken arm or a broken leg, they can see it. With an ulcer, you can't see it. They don't know what the smell is, they don't know where it's coming from, so they judge you on that.
Every individual is different, so you have to engage with that person on their own and address that. Well, no situation is the same. So one of the elephants in the room is pain, and that really needs to be explored in this group of people, because I'm under no doubt do they suffer with pain, sleeplessness, reduced mobility, burning. They've often told me it's like shark bites, bee stings, stabbing. These are some of the terminology, wanting to cut their leg off. So how can you say that person is not in pain?
The hardest part of the leg ulcers was the stigma attached to it. The shit I get off it, the people taking the mick, the smell, the getting into somewhere to live. Yeah, that's the hardest part. Yeah, I've been kicked out of hostels because of non-compliance with appointments and my leg smelling, other residents complaining. Then I've had problems getting into another hostel because of that on the perf, of the fact of the smell. So yeah, it's caused a lot of problems. It just hurts. You know what I mean? When people come out with crap like that, it hurts inside, like, because you're a person, whether you've got a wound or not. Yeah, you're still a person, and it doesn't really matter what you've got wrong with you. People should accept you for who you are. So yeah.
Thank you, Katie. Yeah, so, I mean, that was just a snapshot of what we've been doing, but what we learnt, well, I think it's clear that the system as it's commissioned and it's designed at the moment isn't accessible, and people are living in pain for years, often for years. And I guess the other thing we've also found out is it's often not enough to have just someone to go with you to appointments. A lot of our clients are very, very fearful and frightened, and they need to establish that trust with health workers before they feel able to access support. So I think having outreach, coming out to meet people and making those relationships is really important. And also there's, you know, the evidence, if you're a commissioner who wants to look at the economic arguments about these, the evidence is really clear. So for example, we looked at data from last year for 6 clients going into hospital with leg wounds on an emergency basis. 6 clients for 1 month cost about £60,000. That would fund 1-2 nurses for a whole year. So economically, it makes absolute sense as well. And I think just picking up on one of the points that's just come up in the chat, I think sometimes as frontline workers, we don't always feel confident enough to deal with these issues. So I think it's great that SHP as a whole wants to look at how we can develop our skills in this area. And then what we need, well, I could rant on about this for years, but we really need to get to a place where physical health care is trauma informed. It understands the specific needs of our clients. It's non-stigmatizing. People feel welcome when they seek help for their care, where it's flexible, where there's outreach. And then that's built into the system. And so that the way that we commission for health, it changes so that it's commissioned to be flexible. And I think that's where, leading on into the next section, there's not really anything good about COVID, but one of the silver linings in a way that's come out of it is the real focus obviously on health and on homeless health has forced our commissioners, at least locally, to change how they deliver services and to put in like multidisciplinary teams into homelessness services. So I'm going to hand back over to Eloise to talk you through some of that.
For our talk, I think we're just going to show a quick video. Apologies if anyone saw it yesterday.
It's quite an interesting looking building, but different from most hostel settings.
At the time of COVID landing on us, I was working on an integrated care homeless project with Camden Council and UCLH. And literally one day I received a phone call to say that things were changing and we had to redeploy into the Britannia Hotel. And from the dark cloud of COVID, there has definitely been a huge silver lining in terms of bringing the sectors together, so the acute sector, primary care sector, and obviously the voluntary charity sector, which is the SHP. It became a very evolving process is what I would probably say. And I think a lot of it was about bringing those subject matter experts together and being able to prioritise the safety of both the patients and the staff delivering the care, because SHP was obviously the main provider in terms of supporting the residents or patients on a 24/7 basis. All of us were working in a very untraditional environment, untraditional ways, untraditional methods and approach. There was a lot of things and barriers that traditionally were in place that were all of a sudden broken down, and it gave us the freedom to really just focus on our clinical knowledge and our clinical skills.
The biggest difference between rehabilitation here and engagement here and engagement I've seen over the last 3 years in the hostels is the turnaround and the time frame. So this has been here for 6-7 months. Some of the clients have been here for 3 months, and in that time they've engaged with health, sorted out their health issues, sorted out substance misuse, and moved on out of the homeless pathway.
A lot of people have extensive experiences of services but have in general had really bad experiences, and I think us being able to build those relationships, support and advocate where needed and re-engage, I think has been really, really, really fantastic. And I think that's just been the result of, it's been the result of both the MDT, but it's also been the result of SHP staff being able to take what they need to support them and give them the confidence and the knowledge to drive forward and really understand what is actually there.
I'm thankful for the clients because this also only worked because of the relationship they built with each other and staff. So when something good happened, clients were the #1 fans and spread it round. So the first client that saw the dentist, he then told everyone about the dentist and everyone wanted to see the dentist. So I think really the residents have made it the good journey it's been.
I became homeless, and that was the time that when COVID started. I stayed 3 days on a street, which is I never did in my life. When I came here, it was like a family. A team was here, like everybody was looking after. I couldn't believe it, that many people that can help me out to stay somewhere, and they can provide at least the food on my table every day, morning and afternoon lunch, when I can't afford any money at the moment.
It's provided some certainty in a very uncertain time as well, that they've got their meals, they know where that's coming from, they have adequate housing, that they have staff supporting them on various levels as well. Having all of those things provided, that not being an immediate worry for many of the clients, it kind of puts them in a position to now concentrate and focus on higher level needs, such as their psychological and mental health, emotional needs, social interaction and connection.
Things that were identified within the hotel, I was there. Then when they're in the emergency department working at UCLH, I was there to hand over to the team at UCLH such that the patient received appropriate support.
My role is to try and move them on into whatever accommodation will be suitable for them. We have so much success stories, much more than I thought we could have before I started the work.
I would like to think that we've created such a positive impact, and the experiences for both the staff and for the patients has been ginormous. And I'd like to think that it would create a case for change in how healthcare, wraparound services, acute and primary care all work together to deliver the most effective and the most responsive, holistic orientated care for residents and patients that we interact with on whatever level and whatever service.
If this is replicated in many parts of London with the homeless, the outcome will be wonderful. That's what I can see.
There's so many good stories of outcomes that have happened here that in my experience as a nurse, it would be one time I'll look back and really feel the pride of myself and the team of the supporting the marginalized communities.
So my hope for this is that this is the new normal, that every homeless person experiences this level of care. So I guess it's important to say that the MDT actually came around because of COVID and to work with clients around COVID. So the client you saw in the video talking, AJ, he was picked up off the street and he had 1.5 lungs because he'd had lung cancer. So he'd had half a lung removed, but he also currently had leukemia as well, and he was sleeping rough. So we had quite high vulnerability to COVID. But what we discovered pretty quickly when the MDT came in place was that the main issue wasn't really COVID. We had 83 rough sleepers brought into the hotel who had these horrendous health conditions, which is why they needed to shield, and they had no engagement and no medication. So originally the MDT was just us as SHP, and then we had a nurse and we had someone from UCLH who manages integrated care come on board. And as the MDT grew and the client base grew, word sort of got out, and everyone just wanted to be part of it and the work that was going on, which was great. So there's 2 circles on the screen. The inner circle sort of represents who the main people of the MDT were, and we would come together every day and we'd spend 2 hours virtually, all done by teams, going through every resident in the hotel and their physical health and their mental health, and we would action anything that needed done, and anyone that needed to come on site would come on site to see them, and we had a clinical room. So then the circle around the outside is everyone else that we engaged with who came on site to deliver care. So we had the nurse on site most of the time and she would do all of that stuff. But then we had a dentist, we had a podiatrist, the find and treat guys came and COVID tested, they did HIV testing, Hep C testing. It just sort of grew and grew. We also had wound care on site as well. So it was just amazing really what came on board. And then if you skip to the next slide. Oh, this is just actually the MDT. We talk about it in the video and I've talked about it here, but just to put names to actually who, faces to who was the MDT. This was everyone that came in. It's also really important to note that apart from me, Kieran and Judith, no one else was SHP. So everyone just got redeployed into this hotel and it just worked as a team. There was no, this is how we do it where I'm from. Everyone just took it on board. So these are sort of the outcomes, the major outcomes that came from it. So we only had one COVID case and he was mild and he went away to the care site and came back absolutely fine. So in total, we had 106 clients check in. 35 of them had no GPs and 22 of them didn't even know where their GP currently was. So by the end of me leaving the hotel, which was about a month ago, everyone had a GP and everyone was engaged with their GP, which was huge. But we also had 228 nurse sessions, 16 focus referrals. So focus were the mental health team that were involved and they came on site and assessed and prescribed, which was huge for lots of the residents in there. The podiatrist came and did 20 sessions. We got 4 packages of care. And from the 4 packages of care, we also got 4 move-ons into care homes, which was great. And we had 2 hospital detoxes. And for anyone that's tried to get hospital detox, they're pretty much impossible. So by working with the team so closely and them coming on site, it was just everyone could see the need and the outcome from it. And I think one of the most important things was we had commissioners all the way through and they were part of the MDT. We had 2 commissioners who sat in on every daily meeting. And unfortunately, we did lose 2 clients during the process. And one of the commissioners said that it was the only time in her 20 years that she'd seen them as people and not as names on paper. And I think that's pretty huge, that actually by getting them involved, they can see the impact that they can have if they bring this work together. So we're going to go on to some questions.
I think we've had 2.
Just looking in the question box, but if anyone's got questions, feel free to shout out while I scan up and see.
2 from Peter, I think.
Yeah. Do you want me to say it?
Yeah, it'd be really helpful. Thank you, Peter.
Okay, so a lot of the time when, because I work with the Westminster Floating Support, and so it's not the difficulties that you faced on trying to move people from their homelessness situation into housing or some pathway back into accommodations. But I think it's a very transferable problem, because what actually happens is that the difficulties you face with the low health or the poor health of the clients on the street is there. But when we come across those clients and they're in housing, they've moderated, so they have some sort of access to some health support, and they have tends to be slightly better diets, but the underlying issue tends to be unresolved, like smoking, poor diet, low exercise, etc., etc. So many times I think when the support workers try to generate a conversation, a lot of the time it falls down with, well, what do you know? And when this, and not even when the client says, well, what do you know? It's the support worker themselves are thinking, well, what do I know? You know? So I think a lot of the time, if there was a template of how a client, from your instance, moves from very poor health in, let's say, the Hotel Britannia, moves through the process into, let's say, housing and better health, and their health conditions solved through the MDT. I know this is just, and the data is collected. That template is extremely useful in the background of a support worker or a floating support worker who would pick up, let's say, a client that's moved on into accommodations or TA, and then then the conversations are maintained. So the encouragement is understood, and the journey of how a person got there is also understood, but the actual confidence to have the conversation, because the actual workers see this actually works for certain individuals. Now with an intelligent based system, like with the data as it keeps coming into the system, templates can be picked out for individual cases, you know, to reflect an individual case. So let's say a mental health worker has paranoid schizophrenia, it takes smokes skunk and tends to stop medication. There's a formulaic approach to actually start the conversations around what goes on for the person, where to start from, and to continue on the conversation with that person to perhaps say, well, where does the support worker say, well, he smokes skunk. Well, there is a starting point to say perhaps medication is an essential aspect of that. But with the templates and the support worker seeing that this is an actual, where let's say a psychiatrist or a psychiatric CPN would say, well, this is how we do it, then the support worker has the confidence not only to say and reinforce the information coming from the CPN or the psychiatrist, but to actually reflect back to the psychiatrist and the other workers in the multidisciplinary time, and feel confident that the best care is going to be given to the client, rather than, I feel sometimes we fall for stuff like, oh yeah, the medication is bad, the side effects is bad, etc., etc. You see that kind of stuff, it then goes off into a tangent and is unhelpful to the client over time, you know. So it's these kind of things that I keep thinking about in the back of my head when I'm looking at these kind of problems, because when the person comes out of the hotel and into TA or into someone, then he got to keep it going, and unless there's some sort of awareness for the journey that people do fall, and they meet, things happen, there's triggers, etc., it's to pick it up without actually ending back up there. And I think templates are a very handy thing, and they become incorporated into an Inform or even Microsoft 365 picks it out, you know, it's just picking out data.
Yeah, I know that Eloise will agree with you, Peter, and I don't know, I'm sure she'd like to say a little bit more, because it's been their experience working with floating support clients, and it's something she's asked us to do.
So we have a lot of templates which we used in the hotel. We designed them and used them in the hotel, and our hope is to bring them into hostels, but then to also change them so they're more appropriate for floating support. And another thing we've also been doing is de-skilling to reskill. So taking clients and staff back down to complete basics. So taking everything away from them and building it back up in a positive way and in the steps they should be using. So it is something we're looking at, and we're trying to design it so it will work for floating support as well as for the hostels. So it is there. Hopefully it will be coming soon.
Yes, that's fantastic. And you see, it doesn't have to be like this super artificial intelligence stuff. It just maybe 20, whatever, you know, it is there, you know, but let's say for 350 clients, you don't need a data population that comes in from the whole country to try and figure that out, you see. And simple templates, handwritten stuff sometimes is very, very helpful, you know.
Yeah. And also to answer your other point, Peter, that you'd put in the chat, the council gave us access to a language line. So for any one that came in and didn't speak English, we had a language line. And then if we were bringing anyone on site, they would, to see any of those clients, they would come with an interpreter. So we'd have an interpreter in person and the health professional. So it had a real personal feel to it.
No, that's very good, yeah. Thank you.
Are there any other questions that anybody would like to ask? You can shout them out rather than putting them in the text. Nobody? Always around. You know where you can find us if you have any other questions. Shall we move on to the group sessions now? So I think we're going to break up into two groups now. to have a couple of conversations. We're going to go back to using the website. So have your phones handy again. So again, if you're scanning with your phone, scan now. Otherwise, go to the reference that you can see on the screen. And then what we're going to do is break it. We're going to have 2 discussion groups. So the first one, we're going to move to the next slide. Hopefully it'll still have the details on. So we're asking the group, so with your colleagues in the group, to discuss the challenges that you face in relation to the physical health needs of your clients. And as a group, think about the 3 things that you'd like to see in place to address this. But you don't have to fix them as a group. You can have your differences. When we come back to the main group, and then we're going to ask you to put those 3 things into the answer on your phone. And then once we've done that, we will take you back into groups and discuss another item. So I think we're going to break into groups now. So thank you, everyone. And certainly our group was a lively conversation. Thank you all for sharing your ideas. So we're starting to see what people think we ought to have as part of our core offer. Give you a few minutes to add. Personal training was our last conversation in our group. It's good to see it's on there already. The consistency of who's working with someone, I think, is.
I've lost the link now, sorry. So
the link kept dropping in and out. Every time I went to submit, it just dropped out on me. I apologize.
Don't worry, just shout out whatever you would like to see in there as well, if it's playing up for people.
Yeah, reinforce the advice once the person is there and adopting or making attempts for the support workers and the hostels to keep the advice and the support, a reinforcement of that lifestyle.
Point. Really good point. Somebody else can add it in so it appears on the. I think somebody has added it in so that it.
Maybe it went through. Yeah, maybe someone might because I attempted several times.
So we've got expert in. People can read it. I shouldn't read it all for you. The health checks has come out. Yeah. So, I think have we got everybody in? Last minute if
regular updates.
Perfect. Thank you. Someone put that one in if they can.
I love the more handover. I didn't even think about that, but it's actually such a crucial aspect of planning for someone's well-being. So important.
Perfect. Anybody want to add anything else before we?
I don't think mine went through somehow, but I mean, I think it would be good to have like some kind of, I don't know, maybe like staff and client like health leads within individual services. Like, even if it wasn't like obviously creating a new job, we probably don't have, commissioners might not want to pay for a new job like that but you could even have it in floating support as well, like have a kind of health staff and ideally peer as well, like ambassador for health, I guess, that maybe people could be aware of, that like they can come to that person and maybe that person could get some training and stuff around linking up with health, because I think also a lot of staff like maybe feel pretty uncomfortable, for example, dealing with extreme leg wounds and knowing what to do, or not kind of like, I don't know, feeling uncomfortable around even asking or looking at it, or it's kind of like, so maybe if there was staff who were like taking up some kind of like, and then helping to educate like others in their team a bit more as well, and kind of just getting health a little bit more embedded into our work without us actually becoming people who treat, it's kind of like, yeah.
That's a really good point. And I think somebody's managed to get client health. We've got client health leads, and I think we've got, I saw it keeps moving around every time we add anything. But but I'm sure I
Oh yeah,
saw
there's
it.
a massive one for health leads.
There, it's right in the middle, huge, perfect. Everybody's done it while you were speaking. That's great. Thank you, everybody. It's really helpful to kind of hear the conversation, but also see both groups come together at the end. And I think we'll keep this conversation going. So thank you for that. Shall we move to just kind of what's next slide? So in terms of what we were already thinking, we do want to hold a wider consultation and with a view to informing a wellbeing policy and the very guidance that you've been asking for in these workshops. So we will come back to you, we'll take this workshop forward and we will run others to try and kind of see what's going to have the most impact, both from a client perspective, but also staff. Because we've got all of this data and because we've been able to test the MDT through the Britannia, so it was about the only good thing, I think, as Eloisa said, to come out of COVID was the fact that we had done all this research, we're advocating for an MDT, and then lo and behold, we ended up with one when we thought we had a big fight on our hands. It kind of appeared by magic. And we've got the evidence base now to prove that it works and it makes a massive difference. So what we as an organisation now need to do is collaborate and influence further in other boroughs. So we're having conversations with the biggest boroughs where we've got large rough sleeping services around both putting in MDTs across pathways, but also looking at beds from hospital discharge in hostels and alternatives to care. And on the issue of care, I suppose it's a conversation with our board about when we are arguing that the right level of care isn't available and there aren't specialist care providers out there who can work with our clients. Should we be filling that gap? Should we be looking at CQC registration? Or should we just be asking for social services to fund things better and differently to make sure somebody else is doing it right? Flick, sadly, the money from the big lottery and the programme of works finishes in 1.5 years from now. It's gone very quick. That's the fastest 8 years I've ever known in this organisation. And sorry, I'm just reading loose questions as I'm talking to you. So one of the things that we want to do is make sure that all of the health work that Flick have done is part of their legacy, and Flick are very active with both of the 2 boroughs that they work in terms of kind of making sure that commissioning adopt their recommendations. And in terms of Lou's question, which was who initiated the MDT, it was the CQC, not the CQC, sorry, the CCG in Camden, who made it happen alongside UCH Hospital. So they managed to redeploy an active team that were working with rough sleepers into the hotel at about a week's notice. And it was so disconnected at that start. Everybody wanted to do something, but nobody knew who to speak to. So Eloise and I were in the service on about the end of the first week, and suddenly this team of nurses arrived, and we didn't know who they were, and they didn't know who we were, but everybody just got on with it, and it was pretty amazing. So the other thing that is happening, and has just happened, in fact, is we've renegotiated continuation funding for the sport and health project through Sport England. So that will be looking to adapt what it does and further prove the evidence base. And we are putting health navigation and the ability to put health experts into services into our fundraising strategy and into retenders. So the point that was just raised in the conversation about can we have staff leading on health in services is something that if we can't convince commissioners to fund it, we want to be able to add as added value. And I can't see the bottom of the big slide, and also the point that we were talking about in terms of data and toolkits, we want to be able to assist staff to be able to record and work through health needs better. So both to safeguard the clients they're working with, but also to enable us to campaign. I'm really sorry, my puppy is howling in the background. And I can't read the bottom side, so I can't remember what it is. Can someone shout out?
It says revisions to medication policy and practice.
Okay, thank you. So I think one of the other things that we've learned is where our kind of policy talks about prompting medication, in some situations, we may need to do more than that and look at holding medication for people and assisting in administration, which would come back to the CQC registration question. So we have got time if anybody has a last question or anything we didn't cover that you were hoping that we talk about today. Anything anybody wants to raise at the end? Have I missed any questions in the chat?
I mean, I have a bit of a slightly selfish maybe question, which is we've been working on like staff wellbeing and kind of doing more promotion around that. Like we had a burnout month and a stress awareness month. Email went out this morning, just trying to raise awareness a bit more and get people to engage a bit more with their wellbeing. How and what do you think the overlap or the work, because it feels like in general we should be trying to work together more rather than doing things in silos. So I don't know how we do that, but how do we work together more on like staff and client wellbeing, I guess?
I think one of the things that I know was in the original bid that went to Sport England and was in Vanessa's vision for what we were going to do, and we all kind of lagged behind what Vanessa had in her mind. But what I think she was seeing when we were talking to Sport England were services that were on offer that completely kind of were co-produced between clients and staff. So, and I think the reality is our teams have been as involved in some of the sporting activity as the clients. So I think we need to think about ways of doing other work in the same way, so that, and by equalizing the relationship, the engagement flows. And I just think it's, for anybody who's going to the co-production workshop, I think it happened already, didn't it? But it's the point of it. It's we're working together with clients. We're not doing things to them. We're doing things with them, and it's looking at how we connect the two and have those conversations together.
I think also it's about, like what Tony was saying, building in stuff just for staff. So, I mean, COVID's ruined it, but we did have a yoga bus that was due to come around at the end of this year and offer 7-minute wellbeing sessions just for staff, and then also just for clients. And also it's something we've noticed on the health checks, that when we'll do health checks, staff often want to stand on the scale or have their blood pressure taken. And then with the flu vaccines that have gone round from the find and treat, we've noticed that as well as clients not wanting to get the flu vaccinations, staff also didn't want to get the flu vaccinations. So it's about creating a space, I think, where staff can openly talk about their health and well-being, and because I think it's crucial that that influences how they would then respond to clients' health and well-being as well.
That's absolutely right. When Eloise mentioned the testing, we had the Home Secretary come to a cold weather shelter, and Eloise and Sam and Billy were doing the testing, and there was the strength test, which tells you kind of what your life expectancy might be. We had the Home Secretary doing it, didn't we? I don't think he disclosed what it was, but so is there anything else anybody wants to raise before we close for today? Well, thank you all very much for coming into the session today. As I say, there will be future opportunities to have these conversations, but thank you all so much for kicking it off, and enjoy the rest of the conference week. Nice to see you all.
Thank you.
Thank you. Bye, everyone. Lovely to meet you.
Thank you.
Bye.
Bye.